A very good evening to all. Myself, Dr. Irfan Bashir. I'm working as a senior consultant in the Department of Radiation Oncology at Batra Hospital, New Delhi. So this evening, we have decided to, make the public aware about the causes and prevention of common cancers among men. So first of all, I would like to thank onco.com for organizing such an interactive session. So we have with us in our panel today, we have Dr. Anil Kamath. He's a senior surgical oncologist working at Apollo Hospital, Bangalore. He has special interest in head and neck cancers, lung cancers, gynecological malignancies. So in addition to Dr. Anil, we have Dr. Naresh Somani. So he is a senior medical oncologist at Jaipur. He works in HCG Hospital, Jaipur. And he has a vast experience in the field of medical oncology and a special interest in targeted therapies and immunotherapies. So before we start, I would like to just introduce about the, we will be beginning with head and neck cancers. So as far as head and neck cancers are concerned, these are the common cancers that we see in our day-to-day practices, whether we're talking about a medical oncologist, a radiation oncologist, or a surgical oncologist. So we have lots of head and neck cancers in our day-to-day practices. So when we say head and neck cancers, so this is a very broad term. So head and neck cancers, it has various sites and subsites. So this includes the lips, the tongue, the buccal mucosa, the hard palate, soft palate, the base of tongue. Then we have the oropharynx, and we have the tonsil. Then we come to the larynx, hypopharynx. In addition, we have the nasal cavity and the nasopharynx as well. So there are so many cancers. They all, constitute the head and neck cancers. So talking about the head and neck cancers, the main concern about the head and neck cancers is that in our setting, we get patients in the later stage of the disease. So there are stages of the disease. We have stage 1, 2, 3, and 4. In our setting, in our day-to-day practice, we see patients that usually come to us in stage 3 and stage 4. So what is important is that we actually need to know the causes of the head and neck cancers. And we also need to know how we can prevent these head and neck cancers so that, we catch the disease in early stages and then we can treat them in a better way. So to begin with, we would start with the causes of head and neck cancers, and I would like to, ask Dr. Anil Kamath to please throw some light on the causes of head and neck cancers. Dr. Anil, please.
Yeah, thank you, Dr. Irfan. At the outset, I should thank onco.com for giving us this opportunity. And somewhere I feel men's health is somewhat understated issue. We see a lot of campaigns about breast cancer, not so much about the cancers in men. Though many patients coming in, men's cancer also takes a very important role, I feel. Of course, in India should be termed the head and neck cancer capital of the world because the number of cancers we see, head and neck cancers we see, especially the oral cancers, which we see in India, I doubt anybody else in the world would be seeing that many numbers, especially the Western world, Europe and America. Head and neck cancers or oral cancers form a very small percentage. And in India, head and neck cancer, if there is only one word to summarize, it's because of tobacco. So tobacco forms the root cause of most of the head and neck cancers. And oral cancers, especially in India, it is because of the pan chewing habit, which is widely prevalent in different forms in all the states of India. This pan chewing habit is almost a culture. When we see in North India, the Ganges belt, as we call it, it's almost a culture that many people throughout generations chew pan, and oral cancers at least is directly related to this. In other states also, there are different forms in which tobacco is consumed. It's called by different names in different states. But that is the root cause of oral cancer and most of the head and neck cancers. The tobacco can be in smoking form, the regular smoking of cigarettes and BDs. BDs are widely prevalent in rural India. And in India, what is more common is the smokeless form or the chewing form, which is either in the form of pan masala, betel nut, and all these. They are called different names, kaini or in other states. So this would form the main crux of this thing. And apart from this, alcohol also has got a contributory this thing. Though so many times we fail to mention alcohol because of the common this one, but alcohol has a big contributory role in oral cancers. Not as much as this thing, but it does play an important role. So these two form. But very often we get questions as to, I have never smoked, but still I have got oral cancer. It is possible. It's not that it has to be a rule that only people who smoke have to get, but those who smoke have got a higher chance of getting oral cancer or other head and neck cancers. But it's not that people who have never smoked will never get it. The other causes would be chronic irritation, ill-fitting dentures, sharp tooth. We get that. And now the upcoming cause would be now recently identified cause would be the human papilloma virus. Earlier, this was not very well recognized for oral cancers. It was very well recognized for cervical cancers. But now, for oropharyngeal cancers, at least, human papilloma virus has got quite an important role to play. So to summarize, I think tobacco forms the root cause, both smoking and non-smoking form of tobacco, which means chewing form. Apart from this, sharp tooth, ill-fitting dentures, chronic irritation of different kinds, and then now the human papilloma virus.
Okay. Thank you so much, Dr. Anil, for such a comprehensive. You gave a talk regarding the causes of head and neck cancers. So now I would like to ask Dr. Naresh Somani. So what is your experience as far as the causes of head and neck cancer are concerned that you see in your day-to-day practice? And also you can throw some light as far as the prevention of these head and neck cancers is concerned.
Thank you, Dr. Bashir. Thanks to onco.com. सभी सुनने वालों को मेरा नमस्कार. So Dr. Anil Kamath has told us in a very perfect manner that what are the causes. So coming to the most important cause, that is the tobacco related, gutka related. So I would like to say there is no use of tobacco or gutka. There is only misuse. ये सब जो कहना कि इससे हमारा हेडेक ठीक रहता है, नींद आती है, पाचन शक्ति रहती है, कब्ज नहीं रहती है, ये सब बातें उचित नहीं है, जायज नहीं है. और गुटखा या टोबैको या स्मोकिंग को अगर हम किसी भी रूप में ले रहे हैं और उसको छोड़ते हैं तो जो प्रॉब्लम्स है वो केवल 5 से 7 दिन रहती है और उसके बाद कोई भी फिजिकल जो है डिपेंडेंसी हैबिट है वो नहीं रहती है. इसलिए अपना मन कड़ा करें, इनको छोड़िए. जहां तक कारणों की बात है, सर ने, डॉक्टर अनिल कामत सर ने सारा बताया है, कुछ उसमें और जोड़ने की जरूरत नहीं है. जहां तक हेड नेक कैंसर की बात है, प्रिवेंशन की बात करें तो यस, गुटखा पान तंबाकू से पूर्ण रूप से दूर रहें, स्मोकिंग को किसी भी रूप में नहीं करें और एल्कोहल को हम जितना कट कर सकें उतना कट करें. जैसा कि कहते हैं ना कि 2 और 2 5 होते हैं, तो अगर हम टोबैको च्यूइंग भी कर रहे हैं और उस पर से अल्कोहल भी जोड़ रहे हैं तो वो 2 और 2 4 नहीं है, वो शायद 2 और 2 5 है. ये हमको समझना पड़ेगा. अक्सर हम देखते हैं जो गुटखा खाते हैं, स्मोकिंग करते हैं, वो अल्कोहल का भी सेवन एक्सेस रूप में करते हैं. अपना नियमित रूप से चेकअप कराएं. खास करके जो आदमी हाई रिस्क है उनको प्रिवेंशन के लिए, हेड नेक कैविटी के प्रिवेंशन के लिए नियमित रूप से अपना जो है डॉक्टरी परीक्षण जो है वो कराना आवश्यक है, ताकि अगर प्री कैंसरस चेंजेस हैं. अब प्री कैंसरस चेंजेस क्या हैं? जैसे सबम्यूकोजल फाइब्रोसिस है, मुंह खुलना बंद हो गया, ट्रिस्मस है, ल्यूकोप्लेकिया हो गया है, मेलाकोप्लेकिया हो गया है, एरिथ्रोप्लेकिया हो गया. ये कुछ नाम है जो मुंह के अंदर लाल है या व्हाइट है या ब्लैकिश हो रहा है, कुछ घाव बन रहा है कि जो ठीक नहीं हो रहा है, 7 दिन 10 दिन 15 दिन नॉर्मल ट्रीटमेंट लेने के बाद ठीक नहीं हो रहा है, उसको इग्नोर नहीं करें और तुरंत डॉक्टर को दिखाएं. ये माने कि 2 या 3 सप्ताह से ज्यादा अगर ये तकलीफ बनी हुई है तो ये फिजियोलॉजिकल नहीं है, साधारण नहीं है, ये ऑर्गेनिक है, पैथोलॉजिकल हो सकती है और बहुत ज्यादा संभावित है कि ये कैंसर भी हो सकता है. जहां तक ह्यूमन पेपिलोमा वायरस की डॉक्टर अनिल कामत बात कर रहे थे, तो ह्यूमन पेपिलोमा वायरस जो सर्विक्स कैंसर के लिए कारण होता है, वो मुंह व गले के कैंसर के लिए मुख्य रूप से ओरल सेक्सुअल हैबिट जो प्रैक्टिस है उसकी वजह से होता है। ये सौभाग्य की बात है कि हमारे देश में एचपीवी वायरस जनित जो हेड एंड नेक कैंसर है, वो जितनी भी स्टडीज उपलब्ध हैं विभिन्न माध्यमों से, विभिन्न संस्थाओं से, उसमें ये लगभग 10% या इससे कम ही जो है वो डिटेक्ट होता है। सो हमें भी ये ध्यान रखना है कि हम अपने आप को सचेत रखें, इस तरह की एबनॉर्मल सेक्सुअल हैबिट प्रैक्टिस के अंदर नहीं जाएं और अपनी रेगुलर हाइजीन जो है वो मेंटेन करें। मैं समझता हूं कि आम जन के लिए ये जो चीजें हैं ये उचित रहेंगी प्रिवेंशन के लिए।
Thank you, Dr. Naresh, for such a detailed, talk about the prevention of head and neck cancers. So, if we summarize, I would just like to tell my audience, if we talk about the causes of head and neck cancers, so we have mainly seen that it's the tobacco and the alcohol and the human papilloma virus. These are the causative agents for head and neck cancers. And, when we talk about the prevention of head and neck cancers, so definitely the first thing would be to quit smoking. I would request all those who smoke, they should immediately quit smoking. And for all those who are, chewing tobacco, so actually, as Dr. Anil and Dr. Naresh told you, that it's the gutka or the betel nut that is the main cause of head and neck cancers in our country. So those who are, chewing these betel nuts and gutka, they should immediately stop it. In addition, there has to be some programs at the national level or at the state levels where there are tobacco cessation programs which can help people to quit smoking. And as Dr. Naresh also said, that moderate or no use of alcohol, because it's not the tobacco separate and alcohol separate. When both the things are present together, they act in synergism. So like he said, that it's not 1 + 1 is not 2, it's 1 + 1 maybe 11. So the effect of tobacco and alcohol in a person, when both the things act together, they will definitely lead to head and neck cancers. So before we move to the next section of our talk, as far as for example, we have the breast cancer. There are screening programs for breast cancer. There are screening programs for cervical cancer, but there are actually no recommended screening programs for head and neck cancer. But I would suggest everyone that they should, go for a yearly dental evaluation, and they can also go to some of the local doctors or the family doctors for examination of mouth and the oropharynx. Because just opening the mouth, we can see at least 10 of the sites which I mentioned in the beginning of my talk. So out of the 14-15 sites, 10 sites can be seen just by the inspection of the oral cavity and the oropharynx. So a yearly dental examination and examination of mouth and oropharynx should be fair enough, until and unless we have some recommendations for screening, but at least a yearly examination should be done. So next we'll be talking about the lung cancer. Lung cancer is the commonest cancer in our society among men as well as in women. So I would like Dr. Naresh to speak about the risk factors for lung cancer, and then we can proceed. Yeah, Dr. Naresh, please.
Yeah, lung cancer की जो बात है उसमें again वही smoking जो है, that is the number one cause. And other than smoking जो है, कुछ asbestos exposure है, कुछ chemical radiation exposure है, and ऐसा माना जाता है कि all tubercular scar जो है, that is also being implicated in the causation of the lung cancer. Now people say, and it is being observed also, that especially in the urban population, female population, non-smokers, the current situation of the pollution, urban pollution, is probably also contributing into the development of the lung cancer, especially the adenocarcinoma type of the lung cancer. लंग कैंसर की जब हम इटियोलॉजी या कारण की बात करते हैं तो वी नीड टू अंडरस्टैंड दैट स्मोकिंग जो है वो मुख्य रूप से स्क्वामोस सेल टाइप ऑफ द लंग कैंसर एंड स्मॉल सेल टाइप ऑफ द लंग कैंसर, they are basically producing these kind of the lung cancer. Because it is important to understand that all these histopathology, they have the different ways to treat right from the stage 1 to the advanced stage. So for the awareness program, I will request everyone, those who are present and those who can influence their surrounding, that please keep yourself away from the smoking. That is the main cause, and that is the thing that we can avoid and can prevent the development of the lung cancer, especially the squamous and the small cell types of the lung cancer. Other causes like a lot of chemicals and for the mesothelioma development, asbestos, and they are contributing, but they are not so frequent, and they are probably not affecting population at large.
Okay, thank you, Dr. Naresh. Dr. Anil, can you please throw some light on the signs and symptoms a patient of lung cancer usually presents in our OPD, and how do we approach?
Yeah, this one lung cancer. What signs and symptoms I tell it can mimic other conditions of the lung. Say a person like COPD resulting out of smoking habit can overlap with the symptoms of lung cancer. So basically, anybody with the chronic cough, with long-standing cough, which is not going away, they need to be evaluated for lung cancer. The thing which definitely gives a high suspicion is what we call hemoptysis, or blood in the when the person is coughing in the mucus. If you see blood, especially an elderly person who is a smoker, this is a very common way in which we see this thing. Blood in the when the patient is coughing, that should really alert the person to seek medical attention. Again, not 100% that it is because of, can be due to some other conditions like tuberculosis. Now, the other ways in which we can see, unfortunately, we sometimes see the symptoms of more advanced this thing. Quite often, patient comes with breathlessness. We do an X-ray, we find that there is water accumulation in the lung, and then this water accumulation is because of the underlying cancer. This is another common way in which we see the presentation of lung cancer. Sometimes the lung may totally escape notice, and we might see the features of secondaries. Not uncommon to have a patient with something in the neck, an enlarged node, and then when we evaluate, we find that he has lung cancer. Some patients with hoarseness of voice, we evaluate and we find that it's a lung cancer presenting on the nerve. Sometimes patients present with bone metastasis, extreme pain in the back, and we do an X-ray or an MRI, we find destruction of the bone, and then we evaluate, we see that there is a problem in the main cancer in the lung. So lung cancer is a big mimic. It can spread anywhere, including brain. We have seen patients come with hemiparesis or features of stroke, and then on evaluation we have found. So it can mimic any diseases, but these are by and large, the common cough, hemoptysis, and breathlessness. All these need to be evaluated, especially if a patient is a smoker and of an elderly age.
Okay, thank you, Dr. Anil. So the thing is that as far as lung cancer is concerned, we can have symptoms, that can vary from one system to other system. We can have neurological symptoms, we can have respiratory symptoms, we can have, skeletal, musculoskeletal symptoms, any symptoms, wherever the patient has got the disease. So again, in our day-to-day settings, we have seen that, patients usually come to us in the later stage. We have seen patients presenting with brain mets to us. In the fourth stage, they usually present to us when the situation is difficult, the prognosis is not very good, and the treatment, we don't have many treatment options at that time. So again, the emphasis is on the early, diagnosis and knowing the causes of lung cancer and how to prevent them. So as far as the lung cancer is concerned, again, the things are the same. It's the smoking, which is the commonest cause of lung cancer. So tobacco cessation programs and stopping smoking would be the first preventive factor that needs to be done. Another thing is, as Dr. Naresh told us, that there is exposure of radon and asbestos that are responsible for causing lung cancer. So again, prevention of these exposures can be done, although this is not very common in our setup, but there are certain countries where exposure to radon is the commonest cause of lung cancer. So there can be environmental agencies that can help to reduce this exposure of radon. Similarly, I would also emphasize on the fact that, a healthy A healthy lifestyle, a balanced diet should also be taken into consideration, because having the proper weight and maintaining a good lifestyle also helps in preventing cancers. There are not direct studies for that, but there are definitely associated to each other. So next, I would like to ask Dr. Naresh, as far as the chemotherapeutic agents or the treatments as far as the medical oncology is concerned for the lung cancer, just throw some light in very brief, can summarize the treatment of lung cancer as far as chemotherapy is concerned. Dr. Naresh, please.
Thanks for this opportunity. So before I go for the outline of the treatment, let me add one more point in your discussion. That is the value or the role of the low dose CT scan which is coming. So those people who are at the high risk of developing the lung cancer, especially chronic smoker, heavy smoker, now it is being proven by the various large scale studies that if we do the low dose CT scan, probably it may pick up the lung cancer at the very early stage, and the treatment outcome may be the curative or maybe the improvement in the overall results or the life saving. So that is the one point I would like to add. जहां तक लंग कैंसर के ट्रीटमेंट की बात है, सो लंग कैंसर को हम ट्रीटमेंट आउटलाइन के लिए दो में डिवाइड करते हैं, नॉन स्मॉल सेल लंग कैंसर, स्मॉल सेल लंग कैंसर. सो हमारा फोकस नॉन स्मॉल पे रहेगा क्योंकि वो सबसे कॉमन होता है. अप्रोक्सीमेटली 80% ऑफ द टोटल लंग कैंसर्स आर नॉन स्मॉल सेल लंग कैंसर. सो हम इसको ऐसे समझें, स्टेज 1, स्टेज 2 अर्ली लंग कैंसर हुए, स्टेज 3 लंग कैंसर जिसको भी हम आगे डिवाइड करते हैं लोकली एडवांस लंग कैंसर कहलाएंगे, और स्टेज 4 जो है वो मेटास्टेटिक लंग कैंसर कहलाएंगे. स्टेज 1 एंड 2 लंग कैंसर को बाय एंड लार्ज डॉक्टर अनिल कामत जैसे सीनियर सर्जन, एक्सपीरियंस एंड स्किल्ड सर्जन जो होते हैं, और अगर पेशेंट की कंडीशन अच्छी है तो उसको वो ऑपरेट कर पाते हैं. स्टेज 1 और 2 के लंग कैंसर जो कि स्मोकिंग की वजह से, अन्य कारणों की वजह से, जिनको सीओपीडी है, एस्थमा है, लंग्स की कंडीशन अच्छी नहीं है, लंग्स का रिजर्व अच्छा नहीं है, हार्ट मजबूत नहीं है, सर्जरी के लिए सपोर्ट नहीं है, उनको डॉक्टर इरफान बशीर जैसे रेडिएशन ऑन्कोलॉजी डॉक्टर जो है, उनको अच्छी टेक्निक से रेडिएशन देके, स्टीरियोटैक्टिक एब्लेटिव रेडियोथेरेपी देके उसको भी क्योर करने की या अच्छा कंट्रोल करने की कोशिश करते हैं. स्टेज 3 के जो लंग कैंसर जिनको हम लोकली एडवांस लंग कैंसर बोलेंगे, उसको स्टेज 3 A, B, C ऐसे हम डिवाइड करते हैं. स्टेज 3 लंग कैंसर जो है उसको हम ऑपरेट करके कीमो करने की कोशिश करते हैं, कुछ टारगेट थेरेपी भी देते हैं. स्टेज 3B या 3C जिनको हम अक्सर ऑपरेट नहीं कर पाते हैं, उनको हम कीमो रेडियोथेरेपी दोनों एक साथ देते हैं, प्रोवाइडेड पेशेंट की जनरल कंडीशन अच्छी हो, और उसके बाद टारगेट थेरेपी या इम्यूनोथेरेपी जो भी पेशेंट की अफोर्डेबिलिटी होती है उस टाइम जो कंडीशन रहती है वैसा देने की कोशिश करते हैं. सो ये रूल ऑफ थंब है. आप कभी भी इसको एग्जैक्ट नहीं मानिए, आपका डॉक्टर जो है इंडिविजुअल पेशेंट के लिए ट्रीटमेंट डिसाइड करता है. स्टेज 4 या मेटास्टेटिक जो लंग कैंसर है उनको हम बेसिकली, जो कि हम एक जानते हैं आम भाषा में कीमोथेरेपी है, वो आज भी 50-60% पेशेंट्स में हम अप्लाई करते हैं. जिन पेशेंट्स का PD-L1 मार्कर पॉजिटिव होता है उनको हम इम्यूनोथेरेपी देने की कोशिश करते हैं. कई बार बगैर कीमो के हम इम्यूनोथेरेपी देते हैं. इम्यूनोथेरेपी एज ऑन टुडे काफी महंगे ट्रीटमेंट है, बट यस दे आर गिविंग बेटर रिजल्ट्स कंपेयर टू द कन्वेंशनल कीमोथेरेपी. Now it is very important to understand and to do the tissue test in the stage 4 lung cancer, which we call as the molecular test. Now these genetic based molecular tests which try to detect the molecular abnormalities or the driver mutation which we call them, or the actionable mutation which we call them, they try to find out that in an individual patient what are the molecular abnormalities going on. And according to that, there are various drugs are now being designed and developed and available, which are beyond comparison better than the chemotherapy. And they have replaced to the tune of 30 to 40% of the patient. The chemotherapy has been replaced with these target therapy. They give the better results. They give the more better outcome as far as the quality of the life parameters are concerned. So हमको वो सारी कोशिश करनी चाहिए हार नहीं माननी चाहिए स्टेज 4 लंग कैंसर के अंदर भी कि अब कुछ नहीं हो सकता। नहीं, ऐसा नहीं है। ट्रीटमेंट आउटकम बदल रहे हैं। जरूरत पड़ने पे हम उनको रेडिएशन देके पैलिएट भी करते हैं। कभी सर्जन उनको ट्यूब डाल के उनको आईसीटी भी डालता है, कभी ब्रोंकोस्कोपी करके उनकी ब्लीडिंग भी रोकना पड़ता है। सो बहुत सारे ट्रीटमेंट होते हैं स्टेज 4 में भी। ये एक रूपरेखा है स्टेज 4 या लंग कैंसर को इन जनरल ट्रीट करने की। थैंक यू।
Thank you, Dr. Naresh, telling us about the treatment of lung cancer in such a short span of time. You have, included everything right from stage 1 to stage 4. This is so exclusive. Thank you so much. Next, I would like to ask Dr. Anil Kamath to just, tell us briefly about the role of surgery in lung cancers, and if there are some, recent developments that have happened as far as the surgical oncology is concerned.
Yeah. So, as Dr. Naresh told, my role or the surgical oncologist role is only in early lung cancer. And as we also elaborated, at least in countries like India, if you take, say, about 100, you may not even find 5 cases which are in very early stage. So, though the definite role for surgery is in stage 1 and stage 2 lung cancer, and unfortunately, few patients come in this stage for treatment. As far as surgery goes, it is removal of part of the lung. The lung has different lobes. They are like compartments within the lung. So what we essentially do is try to remove. You can't just remove only the tumor. You have to remove it with some margin. And essentially what we do is the basic surgery is what we call a lobectomy or removal of the lobe. Now, the essential to this is that the remaining lung has to be healthy enough to compensate for the loss of the one lobe. So the lung, if it is unhealthy, it may not expand enough to compensate, and the patient will become oxygen dependent, or he may not be able to come out of the ventilator. So this all has to be evaluated prior to going for the lobectomy or this one. Sometimes we may even have to do a bilobectomy, or rarely a pneumonectomy also. The entire lung may have to be removed. But the basic essence of this one here is that we have to do what we call a pulmonary function test to make sure that the remaining lung is healthy enough to tolerate. Then next comes the various ways in which it has. Traditionally, it was done with what we call a long incision or a thoracotomy incision. But now it's the era of minimally invasive surgery. The same surgery is being done with the keyholes, just 2 or 3 holes, and then a small incision to remove the lobe. So this causes much less pain to the patient. The other way which is coming up is robotic surgery, which is an improvement over laparoscopic surgery where we do with flexible arms. So these are the various surgeries. And apart from removal of the lung, we also sample some of the mediastinal nodes, the nodes which are in the center, or that's a part and parcel of the this one. Since the lung is close to the heart, there are very major vessels. A lot of care needs to be taken while doing this surgery. And if it is not properly done, the patient can land up with very serious complications. So this then just is about the surgery for lung cancer.
Okay, so yeah, thank you, Dr. Anil. So I actually, being the moderator, I don't have to speak much, but I would like to take 1 minute talking about the radiotherapy as far as the lung cancers are concerned. So we all know that the treatment of cancer, it's a multimodality treatment. It cannot be treated with one doctor. It's actually a team of the doctors that treat a particular cancer, whether it's head and neck cancer, it's breast cancer, lung cancer, whatever it is. So as far as lung cancer is concerned, the role of radiotherapy has, become very, very important, because nowadays we have got certain techniques, and we have got good linear accelerators which are very accurate, and they precisely deliver radiation to the tumor area. So you must have heard of techniques like IMRT, intensity modulated radiotherapy technique, and then we have image guided radiotherapy technique, and then we are treating with the arcs. We have rapid arcs, which are very useful in the treatment of the lung cancers. In addition to these techniques, we have the gating techniques, because we know that lung it's a moving tumor. So once we are we are taking the breath in and breath out, so the tumor also moves along with the lung tissue. So we have techniques wherein we can track the tumor. So once the tumor is moving, the beam will also follow the tumor, and we can treat very accurately. Up to sub-millimeter accuracy, we can treat the tumors. So that's the role of the radiation oncology and the newer techniques we have in the, as far as radiation oncology is concerned. Other than this, we have the role in the brain metastasis. When the lung cancer patients present with brain mets, we treat whole brain. We can treat separate lesions with techniques like stereotactic therapies. We can deliver in 3 sessions, 4 sessions, we can complete the treatment. And whole brain also, when we're treating, we can spare the hippocampus, wherein the neurocognitive function of the patients can be saved. So these are the latest techniques that we have available. But coming back to the topic, which is the risk factors, the causes, and the prevention of lung cancer. So again, it's the smoking that's the most common cause for lung cancer. And stopping smoking, whether it's active or passive, and stopping exposure to these gases like radon and asbestos will definitely reduce the burden of lung cancer in our society. So next, we'll be talking about the prostate cancer. So I would like to ask Dr. Anil Kamath to please throw some light on the risk factors of prostate cancer.
Yeah. So prostate cancer, again, a very important cancer in males. So if you see the commonest cancer in males in say USA, that would be prostate cancer, definitely, by and large, much more than any other this thing. In India, we used to think that prostate cancer is not that very common, but we are seeing in all our practice an increasing incidence of prostate cancer. So if the important risk for age itself is a risk factor for prostate cancer. So anybody has crossed the age of 70 or 80, very high chance that he would have some sort of prostatic nodule, and there is quite a high chance that this could be prostatic cancer. So age itself is high stake. So now regarding the different ways in which prostate cancer presents. Now there is another condition called benign prostatic hyperplasia. There is a lot of overlapping symptoms between benign, which is very, very common. Benign prostatic hyperplasia is very widely seen in the society, where a patient comes with difficulty in urination. He has increased frequency. He has to get up many times in the night to pass urine. He has a sense of incomplete urination. So these are the symptoms very often where even a patient with prostatic cancer also presents with. So these symptoms which mimic BPH can be symptoms of prostate cancer also. And very common to find, like in lung cancer, you can find symptoms outside the prostate. That is the metastatic, this one patient comes with backache, we evaluate, we find that there is destruction of the bone and possibly metastasis. And then we do the test, we find that the actual cancer is in the prostate, and what is found in the bone is a secondary. So this is a very common way in which this one. And the other important thing about prostate cancer is that the patient can be quite asymptomatic also. So this is important because prostate is one thing which is regularly screened for in say corporate hospitals when males go for cancer screening. One test which is done is a PSA. And quite often we find that the patient totally doesn't have any symptoms. We find that on a transrectal ultrasound, there is a nodule which is found, and on biopsy, we find that it is actually prostate cancer. So we should remember that a patient with prostate cancer can be totally asymptomatic. So these are some common things about prostate cancer and how it can present.
Okay, thank you, Dr. Anil. In between, I would also like to tell my audience if they have any questions, they can post in the comment section, and we will be very happy to answer their queries. So next, I would like to ask Dr. Naresh to please throw some light on the risk factors and prevention of prostate cancer. Dr. Naresh.
Yeah. So with the permission of Dr. Bashir, before I go for this, there is a question being thrown by the audience that what are the blood tests for the cancer? So yes, there are many blood tests available for many cancers, but not for all cancers. हमें ये समझना है कि सभी cancers को हम टेस्ट से शुगर की तरह या किसी अन्य की तरह नहीं डिटेक्ट कर सकते। जैसे बात करें प्रोस्टेट कैंसर की, जिसकी अभी चर्चा चल रही थी, तो प्रोस्टेट कैंसर के लिए जैसे पीएसए ब्लड टेस्ट होता है, वो हमको डिटेक्ट करने में, डिजीज का स्टेज के साथ साथ में उसका ट्रीटमेंट रिस्पॉन्स असेसमेंट में, और अगर बीमारी दोबारा आ रही है, रिलैप्स हो रहा है, तो उसको मॉनिटरिंग करने में या डिटेक्ट करने में हमको मदद करता है। ऐसे ही आंत के कैंसर के लिए, कोलोन कैंसर के लिए कार्सिनोमा एम्ब्रियोनिक एंटीजन नाम से ब्लड टेस्ट होता है। ये भी कैंसर को डिटेक्ट करने में और सर्जरी होने के बाद उसके वापस आने में या ट्रीटमेंट रिस्पॉन्स असेसमेंट में मदद करता है। सभी कैंसर्स के लिए, जैसे हेड नेक कैंसर के लिए, लंग कैंसर के लिए ब्लड टेस्ट वगैरह नहीं उपलब्ध है। साइंटिस्ट जो है, साइंटिफिक कम्युनिटी है, इस दिशा में बहुत काम कर रही है, बट एज ऑन टुडे जैसे बोलते हैं ना, वन स्टॉप सॉल्यूशन और वन ड्रॉप ऑफ द ब्लड एंड डिटेक्टिंग द कैंसर और प्री कैंसरस कंडीशन, as on today they are not available for each and every type of the cancer. So that means we need to do the more prevention rather than keep doing the wrong habits and then thinking that yes, doctor will diagnose it with the help of some test and we will be cured again. जहां
Okay,
तक कि
thank you.
मुझे so now coming to the prostate cancer. So एक बात मैं इसमें और ऐड करना चाहूंगा विद डॉक्टर अनिल कामत कि इंडियन सिनेरियो में ब्लैक पॉपुलेशन में दुर्भाग्य से प्रोस्टेट कैंसर जो है वो एक डिकेड अर्लियर आ जाता है लगभग। सो ये भी हमको इसके सिम्टम्स को समझने में ध्यान रखने की बात है कि प्रोस्टेट से रिलेटेड सिम्टम्स को हम इग्नोर नहीं करें। और ये थोड़ा सा बायोलॉजिकली भारतीय पुरुषों के अंदर थोड़ा ज्यादा एग्रेसिव होता है, बायोलॉजी इसकी खराब होती है, जल्दी फैलता है, ट्रीटमेंट के रिजल्ट्स आउटकम भी उतने अच्छे नहीं होते हैं। जहां तक इसका प्रिवेंशन की बात है तो देखा गया है कि एक्सेस अल्कोहल जो है वो इसको कुछ करता है, स्मोकिंग इसको कुछ करता है, कुछ हेरिडिटरी फैक्टर्स होते हैं जिसको कि हम नहीं बदल सकते हैं, बट स्मोकिंग अल्कोहल को कट करें हम, रेगुलर एक्सरसाइज करें और मोटापा अगर हम कम करें तो हो सकता है कि प्रोस्टेट कैंसर के बचाव में भी कुछ मदद मिलेगी। ऐसे ही कुछ पेशेंट्स में प्रोस्टेट कैंसर जो है उसके लिए ब्राका जीन जो है वो 1 से 2% पेशेंट्स में जिम्मेदार होता है, जिसको कि हम ब्लड टेस्ट द्वारा या टिश्यू टेस्ट के द्वारा डिटेक्ट कर सकते हैं, उसका इलाज भी कर सकते हैं। जहां तक प्रोस्टेट कैंसर के इलाज की बात है, इसको भी हम लंग कैंसर की तरह ही समझना चाहेंगे। अगर बहुत अर्ली स्टेज का प्रोस्टेट कैंसर है तो सर्जन डॉक्टर जो है, कैंसर सर्जन या यूरोलॉजिस्ट जो है, जो इस चीज में एक्सपर्ट होते हैं, वो इसकी रेडिकल प्रोस्टेक्टमी सर्जरी करते हैं, पूरा प्रोस्टेट बाहर निकालते हैं और जरूरत पड़ने पे उसके बाद उसका रेडिएशन भी आवश्यक होता है कुछ पेशेंट्स में, खास करके जिनमें पीएसए वैल्यू 0 नहीं अचीव हो पाते। ऐसे ही जो पेशेंट प्रोस्टेट कैंसर के अपनी जगह पे बीमारी थोड़ा सा बढ़ जाती है, सराउंडिंग की तरफ जाने लग जाती है, प्रोस्टेट कैप्सूल से बाहर निकलने लग जाती है, वहां हम ये सोचते हैं कि शायद उनको हार्मोन थेरेपी देके और बाद में रेडिएशन अप्लाई करें तो रिजल्ट्स उनके इम्प्रूव होते हैं और इसमें से कुछ पेशेंट्स को हम क्योर भी करते हैं। जो प्रोस्टेट कैंसर के पेशेंट स्टेज 4 या स्प्रेड हो जाता है, जिसमें सबसे कॉमन साइट बोन मेटास्टेसिस, खास करके स्पाइन या वर्टिब्रल मेटास्टेसिस सबसे कॉमन होते हैं। स्टेज 4 प्रोस्टेट कैंसर जो है उनका मुख्य ट्रीटमेंट जो है वो हार्मोन थेरेपी कहलाता है। हार्मोन थेरेपी का मतलब ये होता है कि प्रोस्टेट कैंसर जो है वो टेस्टिस से निकलने वाले टेस्टोस्टेरोन हार्मोन पे डिपेंडेंट होता है। सो हमें टेस्टोस्टेरोन हार्मोन को खत्म करना है, विच कैन बी द केमिकल बाय वेरियस इंजेक्शंस, विच कैन बी बाय द सर्जिकल मेथड। सर्जिकल मेथड मीन्स हम दोनों टेस्टिस को ऑपरेट करके निकाल दें, ऑर्किडेक्टमी कर दें। सो वो परमानेंट उसका सॉल्यूशन है। इसके अलावा बोन्स के अंदर जो बीमारी होती है, जो रिसेप्टर्स होते हैं, एंड्रोजन रिसेप्टर्स जिसको हम बोलते हैं, उसको कंट्रोल करने के लिए हम नई दवाइयां जो है, जैसे बाइकालुटामाइड है, एंजालुटामाइड है, एबिराट्रोन है, या कुछ पेशेंट्स में जिसमें बहुत डिसेमिनेटेड डिजीज होती है, सिम्टम ज्यादा होते हैं, हाई वॉल्यूम मेटास्टेटिक डिजीज होते हैं, ऐसे कुछ क्राइटेरिया होते हैं जिनके अंदर कुछ पेशेंट्स में हम अपफ्रंट कीमोथेरेपी भी करते हैं। ये प्रोस्टेट कैंसर स्टेज 4 का फर्स्ट लाइन एक ट्रीटमेंट की गाइडलाइन से आउटलाइन होती है। ये सीक्वेंशियल ट्रीटमेंट भी होता है, इसमें कोई ट्रीटमेंट गलत या सही नहीं होता, डॉक्टर पेशेंट से या फैमिली से डिस्कस करके ट्रीटमेंट को फॉर्मुलेट करता है। बेसिक जो क्रक्स ऑफ द ट्रीटमेंट है दैट इज द हार्मोन थेरेपी। plus minus chemotherapy in the few select patients. This is how we treat the prostate cancer in the first line. That to Dr. Irfan.
Yeah, thanks, Dr. Naresh. Dr. Naresh and Dr. Anil both have, spoken about the prostate cancer, its risk factors and prevention. So to summarize, it's actually the older age, greater than 50 years of age, that patients are at a risk of developing. So age is actually a risk factor for the prostate cancer. And then obesity is again a risk factor. So once we come to the prevention of the prostate cancer, so maintaining a healthy diet and maintaining a good weight should be important as far as the prevention of prostate cancer is concerned. And another thing is that in elderly, they should get a serum PSA done. So because serum PSA, this is the screening test for cancer of the prostate.
Dr. Irfan, sorry to interrupt you. Sorry. There are a lot of questions being posted on our group, webinar group.
Yes,
so you can go through them. And I think it will be better. Sorry to interrupt.
Yes. No, it's okay. So coming back to the prevention of prostate cancer, I was saying that it's important to maintain a healthy lifestyle. And there are certain, studies that have shown that consumption of certain fruits and vegetables have shown to decrease the risk of prostate cancer, especially some vegetables and fruits which are rich in lycopene. For example, tomatoes, they are rich in lycopene. There are studies that have been done, and they have shown that consuming tomatoes has shown to decrease the incidence of prostate cancers. So serum PSA, getting the annual prostatic specific antigen test done, and maintaining a healthy lifestyle, maintaining a good weight, and eating healthy diet which is full of fruits and vegetables. That's how we can prevent prostatic cancer. So we have lots of questions in the comment section. We'll be answering them offline, but we will take a couple of questions online before we conclude the session. So I would like to ask Dr. Anil, there's one question that somebody is asking that do non-smokers also get lung cancer? So Dr. Anil, if you can take this question, it's a very interesting question.
Yeah, most definitely, yes. The smoking habit, fortunately, has come down. If you see, the number of smokers has come down, but the number of lung cancers has not come down proportionately. And I think Dr. Naresh also spoke about it. The type of lung cancer differs, and the adenocarcinoma is more common in non-smokers, whereas squamous carcinoma and small cell carcinoma is more common in smokers. And non-smokers also do get lung cancer, and this can be attributed either to passive smoking or due to environmental pollution. And the other variety, the adenocarcinoma, is more common in non-smokers.
Yeah. So next question we'll take, Dr. Naresh may answer this question. There's a question that is enlargement of prostate again a sign of cancer? Dr. Naresh, please.
So as being explained by Dr. Anil previously, that is enlargement, usually the BPH or the benign prostatic hyperplasia per se is not the cancer. It's a benign condition, as the name suggests very clearly. So we should not get afraid of that. But yes, it is being correlated often with the PSA values. And if the PSA values are disproportionately high, or the free PSA or the density ratio, and so many ways are there to calculate and to understand, then we often do the biopsy to rule out or to exclude that, yes, there is a cancer or there is no cancer in this enlarged prostate in individual patient.
Yeah, thank you, Dr. Naresh. We have many more questions, but we will be answering them offline. So to summarize, I would just like to tell my audience that if anybody has got any symptoms that are persisting, and they should not self-medicate, they should immediately go and consult their doctor. Maintain a healthy lifestyle. If somebody is smoking, they should immediately quit smoking. And I think a yearly checkup by a clinician is an important, point, and it can help us to diagnose the disease in the very early stage. Even if we get a blood test like a complete blood count, a liver function and a kidney function test done, and if we see that the liver functions are deranged, we can get the ultrasound done, and in an ultrasound we can find that there is something in the liver. So this is how we can diagnose things. So even simpler tests can also help us to reach to some conclusion. The crux is that one should not self-medicate. Anybody who has got symptoms that are persisting, they should immediately consult a doctor, a clinician, and get their evaluation done. At the end, I would like to thank Onco.com for organizing this session and giving us this platform to reach our audience. And we hope that we have similar sessions in future. I would convey my special thanks to Dr. Anil Kamath and Dr. Naresh Somani. And thanks once again to Onco.com. Have a great evening, everyone.
Thank you.
Thank you.
Thank you so much. Thanks. Bye.